So today we will discuss another type of stroke, which is haemorrhagic stroke. There are two types of haemorrhagic stroke: intracerebral haemorrhagic stroke and subarachnoid hemorrhage. Now we will discuss that what can be the causes of this haemorrhagic stroke. Most common cause in older people or middle-aged people is uncontrolled hypertension. Then in youngsters it can be AV malformation, aneurysms, and then trauma that can lead to subdural or extradural hematoma. Then there can be bleeding disorders like congenital and acquired because of decreased platelet count, because of DIC, because of liver disorders. They can also produce these intracerebral hemorrhages. Then after that, we will discuss about symptoms and signs of intracerebral hemorrhage and subarachnoid hemorrhage. So symptoms and signs are because of increased intracranial pressure. There is a surrounding edema around hemorrhage. So patient can present with severe headache, vomiting, fits, altered state of consciousness, and depending upon that which area of brain is involved, there can be hemiplegia or there can be different cranial nerve palsies. For example, if posterior cranial fossa structures are involved, then third, fourth, sixth cranial nerves and they can be involved. While in interior circulation, seventh nerve it can be involved. Then there can be cerebellar features as well if cerebellar hematoma is present. So depending upon that which area of brain is involved, there can be different kind of manifestations. In subarachnoid hemorrhage, patient usually presents with worst headache of the life or thunderclap headache. In subdural or extradural hematoma, subdural hematoma usually occurs in older age group. Initial injury which has caused, it can be trivial or patient might not remember it, while in extradural hematoma, patients are youngsters and they remember trauma. And then in both of these, there is lucid interval. It means that patient he becomes confused and then becomes all right and then again becomes confused. So fluctuating consciousness is hallmark of subdural and extradural hematoma. Then after that, after symptoms and signs, we will discuss about investigations. Investigation is obviously CT scan. This is the initial investigation in which we can localize that whether it is intracerebral hemorrhage or if it is subarachnoid hemorrhage, it is subdural or extradural. So this is intracerebral bleed which is extended into the ventricle, and the gray area that is surrounding this bleed is cerebral edema. So this is CT of subarachnoid hemorrhage, white blood in sulci. Sometimes CT is normal, but still we are suspecting this. Then we can perform LP after 7 to 12 hours, which shows xanthochromia. Then this is subdural hematoma. You can see here a white crescent. It is acute subdural hematoma. In chronic subdural hematoma, this it gets black. Then this convex white shadow is extradural hematoma. Treatment is of course supportive for reducing brain edema. We give mannitol, then we give fluid, then control of blood pressure, blood sugar, bladder and bowel care, evacuation if it is producing mass effect, and nimodipine, which is a calcium channel blocker, which actually prevents secondary vasospasm, which is more damaging than subarachnoid hemorrhage itself. So these are the complications of hemorrhage. It can produce mass effect and it can compress vital centers in the brain like vasomotor center and respiratory center, syndrome of inappropriate ADS secretion, and hydrocephalus and reactionary vasospasm, which is more damaging as compared to subarachnoid hemorrhage. So we give calcium channel blocker, nimodipine, 60 mg QID for 21 days. Then there are chances of rebleed as well. Thank you.